So this is chapter 13, Substance-Related and Addictive Disorders, review from the PMHMP Review and Resource Manual 4th edition in preparation to take my ANCC board examination probably in the next 2 weeks, 2 to 3 weeks. So this is just me recapping what the book says about these disorders. One of the most common but least well addressed classes of disorders is substance use disorders. Many substances can be used and abused. No matter what the substance, the continuum of use can range from mild to severe. Although the specific substances of abuse will determine many of the physical, behavioral, and cognitive symptoms exhibited by the client, some commonalities exist for all drugs. New to the 5th edition of the Diagnostic Manual, the DSM-5, is the inclusion of gambling as a behavioral addiction. And this was in 2013. Gambling was added. Obviously, we're in 2024 right now. But anyway, this chapter focuses on the PMHMP role in determining the severity of substance use and available clinical management and treatments. It also emphasizes alcohol use disorders as a primary example. Alcohol is discussed because it is the most commonly abused substance, it is well researched, and PMHMPs will most often encounter people in the clinical setting with an alcohol use disorder. Much of what is known about disorders of alcohol use is believed to be transferable to other substances. Substance-related disorders. Description. Substance use disorders are a cluster of disorders in which cognitive, behavioral, and physiological symptoms indicate that a person continues using a substance despite significant substance-related problems. Psychiatric symptom clusters may be related to substance use, discontinuation of substance use, or withdrawal from habitual substance use. Substance use disorders lead to changes in brain circuits and physiological functions that lead to a need for detoxification and a possible need for long-term treatment. The word substance can describe a drug of abuse, a medication, or a toxin that produces psychoactivation and alters cognitive, behavioral, and affective perceptions. Psychological dependence is the repeated use of a substance with or without physical dependence. Abuse is use that is inconsistent with sociality use patterns. Misuse is usually applies to a prescribed substance. Generally, the word misuse applies to a prescribed substance. And intoxication is the reversible syndrome caused by a specific substance affecting memory, judgment, behavior, or social or occupational functioning. Withdrawal is substance-specific symptoms that occur after stopping or reducing using the substance. Intolerance is needing more of the substance to get the desired effect. Etiology is multiple theories ranging from psychological to neurobiological. Probable multifactorial etiological picture. Two common types of theories are the psychodynamic and biological theory. The psychodynamic theory are behaviors of abuse are seated in the oral stage fixation. A person seeks gratification through oral behaviors. Maladaptive regressive behaviors can become overlearned, fixed, and reinforced through dysfunctional family patterns. Sociocultural factors attempt to explain population-based differences in substance abuse rates. Biological theory. Genetic loading. People with strong genetic vulnerability to addiction are thought to have defects in the working of the reward center of the brain, which predisposes them to stronger than normal positive rewards that draw them to substance use. There's gender differences, ethnic differences, and a person is predisposed to stronger than normal negative rewards, making it more difficult to stop abuse once it has become. And that falls under genetic loading, biological theory of genetic loading. This involves two neurobiological processes. The biological theory, and we talked about genetic loading, and now we'll talk about involving two neurobiological processes. One is reinforcement and the other is neuroadaptation. So we'll start with reinforcement. This is a brain-based changes in structure and function can lead to addictive behavior. The process of positive and negative rewards is physiologically linked to memory function. Changes appear to occur with any drug of abuse. Reinforcement results in the feel-good sensations when a drug of abuse is used and a feel-bad sensation when the drug exits the body. Positive rewards of reinforcement result in the social rewards commonly associated with drug use, such as disinhibition, euphoric mood, and anxiety reduction. It's mediated by dopamine pathways. Negative rewards are aversive, such as increased anxiety and dysphoria, mediated by GABA pathways. So I'll repeat, positive reward reinforcement are mediated by dopamine pathways, and negative rewards are aversive, such as increased anxiety, are mediated by GABA pathways. Reinforcement occurs in the ventral tegmental area and the nucleus accumbens of the brain, collectively called the reward center. I'll repeat that. Reinforcement occurs in the ventral tegmental area and the nucleus accumbens of the brain, collectively called the reward center. Neurobiological process of reinforcement continued. Okay, so dopamine release within the reward center is enhanced further by the release of natural morphine-like neurotransmitters called neuropeptides, which are enkephalins and beta endorphins. Neuropeptides further enhance the reinforcement pleasure experienced by the person. With repeated drug use, the dopamine system becomes increasingly sensitized. Eventually, associated drug use stimuli can cause dopamine release, leading to reinforcement of use and often to increased drug use. So, associated drug stimuli such as pictures of a drug or paraphernalia can cause a dopamine release, leading to reinforcement of use and often to increased drug use. Neurobiological process of neuroadaptation. So this is another part of the biological theory, and this is neuroadaptation. So this is a brain-based changes in structure and function that can lead to tolerance and withdrawal. That's with neuroadaptation. They can lead to tolerance and withdrawal. Drug-specific alterations in the normal level and function of neurotransmitters occur as the body adapts to the chronic presence of the substance of abuse. Neuroadaptive processes become very significant when the person stops substance use. Neurobiological process of neuroadaptation continued. These processes become the basis for withdrawal symptoms because adaptive responses are unopposed when the substance is no longer present. Neuroadaptive changes may be more enduring in some persons, possibly lasting for years, thus increasing their potential for relapse. The concept helps to explain why, after a long period of sobriety, a person who returns to substance abuse often picks up at the same level of tolerance and physical impacts as experienced before sobriety. Incidence and demographics. Persons ages 18 to 24 years of age have high prevalence rates for using most substances. The United States has higher rates of substance use than any other developed country. More than 50% of U.S. clients with a psychiatric disorder have a comorbid substance use disorder. Persons with schizophrenia are 4 times more likely to have substance use comorbidity than the general population. Persons with bipolar affective disorder are 5 times more likely to have a substance use comorbidity than the general population. More than 2 million admissions annually are made to inpatient substance use treatment facilities. Though now legal in some states, marijuana is the most commonly abused illegal substance. Alcohol is the most commonly abused legal substance. Rates are higher in men than in women. 90% of men have used alcohol and 70% of women have used alcohol. Rates are highest in African Americans, Hispanic Americans, and Native Americans, and rates are lowest in Asian Americans. 55% of fatal driving accidents in the United States occur with a driver under the influence of alcohol. 50% of crimes in the United States are committed under the influence of alcohol. The lifetime risk for alcohol use disorder is 15% in the general U.S. population. Risk factors. There's genetic loading, family history of substance abuse or major depressive disorder, association with peer structure and heavy substance use, co-occurrent psychiatric disorder, age and gender, younger and males, existence of chronic pain, untreated chronic pathological level anxiety. Implications of alcohol and other drugs of abuse during pregnancy. There's fetal alcohol syndrome. The prevalence of fetal alcohol syndrome is 1/3 of all infants are born to females with alcohol use disorder. Signs are low birth weight and height, microphthalmia, short palpebral fissure, midface hypoplasia, smooth or short philtrum, thin upper lip, and birth defects. Alcohol intoxication in non-tolerant persons, such as teenagers, can result in coma, respiratory depression, and death. The CAGE questionnaire is administered by asking the client 4 questions. Each positive answer has a score of 1. The more positive answers, the greater the likelihood of an alcohol use disorder. If clients who scored 2 or more are at mild to moderate risk, and clients who score 3 or 4 are at a high risk. CAGE is C for cut down. Have you ever felt the need to cut down? A is for annoyed, or people annoyed you by mentioning your drinking. G is guilt. Have you ever felt bad or guilty about your drinking? And E is eye opener. Have you ever had a drink first thing in the morning to steady your nerves? Eye opener. And I believe there's a modification of this now to be applied to other drugs of abuse, but CAGE is originally was just very specific for alcohol. Other screening is audit. This is alcohol use disorders identification test. It's more complete than the CAGE. So the CAGE would be the initial evaluation to see if there is a problem. In audit, talks more about details about the abuse, probably its severity. SMAS is the Short Michigan Alcohol Screening Test for the geriatric version. Talks about consequences as well. It includes consequences of drinking. CRAFT is used for children and adolescents under the age of 21. And COWS is the Clinical Opiate Withdrawal Scale. They talk about CIWA later. Assessment. A detailed history of present illness, including time frame progression and symptoms, social history, medication use, initial and periodic functioning history and assessment, and validate history with a family member. Identify the category of drug abused by the client. Knowing the category allows for anticipation of physical impact of the drug and to predict potential symptoms of withdrawal. Clients often abuse drugs from categories with similar pharmacological properties. Some categories are alcohol, amphetamines, caffeine, cannabis, and the list goes on. Assess for the presence of substance abuse. So maladaptive pattern of substance use manifested by recurrent and significant adverse consequences related to repeated use of a substance is not synonymous with use, misuse, or hazardous use. Specific criteria needed to identify substance use as abuse is a maladaptive pattern of use occurring for at least a 12-month period of sustained use, must be accompanied by repeated failure to fulfill major role obligations, and must be accompanied by use in situation that presents as physically hazardous, such as drinking and driving. I think that was a practice test question. So must be accompanied by use in situations that present as physically hazardous, such as drinking and driving. Abuse continues despite multiple problems related to the substance use patterns, such as legal, interpersonal, and social problems. Assess for presence of substance use disorder. Cluster of cognitive, behavioral, and physiological symptoms indicating that the person continues to use the substance despite significant substance use related problems. It is synonymous with addiction. Substance use disorder is synonymous with addiction, which is a pattern of repeated use that leads to clinically significant impairment or distress with 3 or more of the following symptoms within a 12-month period. And here are some of the symptoms: tolerance, withdrawal, using larger amounts than intended, persistent craving or unsuccessful attempts to cut down, large amount of time spent obtaining the substance, using the substance, or recovering from its effects, activities decreased or given up because of the use, and using despite negative consequences. Physiological dependence implies tolerance and withdrawal. The degree of tolerance and withdrawal symptoms are substance specific, can be physical, physiological, or both depending on the substance. Withdrawal symptoms are almost always the opposite of the acute action of the substance. Categories of abused substances with pronounced obvious withdrawal symptoms are alcohol, opiates, sedatives, hypnotics, and anxiolytics. Categories of abused substances with less pronounced, less obvious withdrawal symptoms are stimulants, nicotine, and cannabis. Categories of abused substances with little or no pronounced obvious withdrawal symptoms also include hallucinogens and PCP. Okay, and so assess for the presence of substance withdrawal or intoxication. Clients abusing substances present for assessment either under the influence of the drug intoxication or experiencing problems related to cessation or substance use, which is withdrawal. Intoxication is the reversible substance-specific syndrome caused by recent ingestion of a psychoactivating substance. Withdrawal is potentially a non-reversible substance-specific syndrome caused by cessation or significant reduction in heavy, prolonged use of a substance. Blood alcohol levels determine the presence of alcohol in the body. Tolerant persons often have higher blood levels with less impairment than non-tolerant persons. Blood alcohol levels must be interpreted based on the client and his or her degree of tolerance. Diagnostic criteria for substance withdrawal is cessation or reduction in substance use that has been heavy or prolonged, and 2 or more of the following symptoms within several hours or days of the reduction or cessation of the substance. And these are hand tremor, insomnia, autonomic hyperactivity such as sweating or increased heart rate, increased blood pressure, nausea and vomiting, hallucinations or illusions, psychomotor agitation, anxiety, and seizures. Structured interview allows for assessment of the use patterns and consequences of a person's substance use. Assess for all dimensions of the impact of substance abuse or dependence in the person. Current use, pattern of use, consequences, interpersonal, occupational, legal, or physical health consequences. Physical exam findings. Substance abuse or dependence produces many physical symptoms, usually a result of the sequelae of use or abuse rather than findings specific to the abuse or dependence. Generally nonspecific when viewed in isolation. Must be considered as a cluster of symptoms that raise an index of suspicion for addiction potential. These symptoms are abdominal pain and tenderness, nausea, weight loss, GI bleeding, hypertension, anxiety, and first episode seizure in an adult. First episode of seizure in an adult. Physical findings related to alcohol use disorders. For the brain, there's mood changes and behavior changes. Head, ears, eyes, nose, and throat, there's poor oral health. Cardiovascular, it's hypertension, cardiomyopathy, and tachycardia. Gastrointestinal are liver disease, cirrhosis, peptic ulcer, and esophageal malignancies. Neurologic, there's tremor, cognitive deficits, peripheral neuropathy, and Wernicke-Korsakoff's syndrome. And metabolic, there's hyperlipidemia. Mental status exam findings. The nature of the findings depends heavily on whether the client is experiencing substance intoxication or withdrawal, or is substance-free at the time of the assessment. The index of suspicion for substance-related disorder should be raised if the client presents differently during different episodes. If the client presents differently during different periods of assessment. mental status findings continued. So, with stimulants, we might find agitation, anxiety, irritability, mood swings, and elevated mood. With opioids, we might find mood swings, aggression, disinhibition, impaired cognition, slurred speech, and psychomotor slowing. With hallucinogens, it might be mood swings, hallucinations, paranoia, flashbacks, panic, impaired judgment. Cannabis, there's confusion, paranoia, and panic. Inhalants, there's agitation, irritability, confusion, and hallucinations. Diagnostic and laboratory findings. Complete blood count, chemistry profile, thyroid function test, B12 to rule out metabolic causes. So the same labs again than for all the psychiatric conditions, or most of them at least. Drug toxicity screening, if indicated by history. Alcohol use dependence and abuse produce characteristic laboratory findings, and that would be a blood alcohol level greater than 100 milligrams per deciliter. It says outpatient, greater than 150 anytime with symptoms, and greater than 300 milligrams per deciliter at any time. Aspartate transminase, or AST, and ALT ratio greater than 2.0. Elevated glutamyltransferase, or GGT, mean corpuscular volume, prothrombin time, uric acid, total cholesterol, and triglycerides. And decreased magnesium, calcium, potassium, blood urea, nitrogen, hemoglobin, hematocrit, and platelet count, and albumin. So all of that is decreased in alcohol use. So that's magnesium, calcium, potassium, blood urea, nitrogen, hemoglobin, hematocrit, platelet count, and albumin. Differential diagnosis is endocrine disorders such as Cushing's disease, neurological disorders such as seizure disorder, cardiovascular disorders such as myocardial infarction, mood disorders, major depressive or bipolar, anxiety disorders, personality disorders, and differential diagnostic consideration for acute alcohol withdrawal. Many acute general health conditions can mimic the symptoms of alcohol withdrawal. For clinical management, rule out or treat any conditions that may contribute to the clinical findings. Note that 80 to 90% of people who require alcohol treatment do not get it. Common reasons for failure to receive the needed treatment are lack of a diagnosis, lack of referral, access to services, lack of access, and resistance to treatment. The genetics of addiction vulnerability are becoming better known, which allows for the preventative and early intervention treatments. The knowledge base of the pathophysiology of dependence has prompted new somatic interventions. Psychopharmacology offers the promise of a new era in the treatment of addictions. Yep. Clinical management continued. Clinical management differs depending on the substance-related syndrome exhibited by the person. There's acute withdrawal, acute intoxication, long-term sobriety maintenance, relapse prevention. Alcohol withdrawal carries a high risk of mortality. Clinical management of alcohol withdrawal is a specialized treatment that requires specific experience in this type of area. Alcohol withdrawal carries a high risk of mortality. Some clinical findings may assist in the identification of clients at risk for severe alcohol withdrawal. There's agitation, decreased short-term memory, disorientation, hallucinations, irregular pulse, or ophthalmoplegia. From the previous slide, ophthalmoplegia is I looked it up. And it says it's a condition that causes paralysis or weakness in the extraocular muscles, which prevents the eye from moving. And there's two subtypes, external and internal. All right, moving on to this slide is CIWA. So, Clinical Institute Withdrawal Assessment for Alcohol, CIWA. It's used to determine the likelihood of withdrawal and delirium tremens, which usually occur within the first 24 to 72 hours after the cessation of alcohol. Assess 10 common withdrawal symptoms. 10 common alcohol withdrawal symptoms. That's what the CIWA assesses for. Nausea and vomiting, tremors, paroxysmal sweats, anxiety, agitation, tactile disturbances, auditory disturbances, visual, headaches, and altered sensorium. And I learned in clinicals that assessing tremors is very much easier to do by looking at the person's tongue, having them stick out their tongue. Part of the previous slide with CIWA is that each symptom is graded on a 0 to 7 point scale, with the exception of orientation and sensorium, which are graded 0 to 4 point scale. The higher the total score, there's a maximum of 67. Then the more likely the person will experience experiencing severe withdrawal or possibly DTs. Scores at 0 to 9 are absent or mild withdrawal, 10 to 15 are mild, 16 to 20 is moderate, and 21 to 67 are severe. So the maximum is 67. Now this slide is pharmacological management. Pharmacological treatments are symptom-specific. Clinical management of acute withdrawal. Detoxification, often called detox, agents replace uncontrolled use of substance with slow tapering of controlled substance to minimize neuroadaptive rebound. Multiple daily doses of benzodiazepines are used according to a fixed schedule and gradually tapered down over several days. Examples include lorazepam, Ativan, chlordiazepoxide, which is Librium, diazepam, which is Valium, oxazepam, which is Serax. Polytherapy is a newer approach that matches drugs required for safe and effective withdrawal with neurotransmitter deficits created by the substance use. Selective serotonin reuptake inhibitors, or SSRIs, opioid antagonist, which is nalmefene hydrochloride, that's Revex, naltrexone, which is Revia, or naltrexone for extended release injectable suspension, which is Vivitrol. And there's also NMDA agonists. There's anti-seizure medications such as carbamazepine, Tegretol, and valproic acid, Depakine, are sometimes used to decrease the potential for seizures. Adrenergic medications are sometimes used to address blood pressure and pulse rate associated with withdrawals, like clonidine. Clinical management of craving. Use of anti-craving medications such as naltrexone, Revia, or acamprosate, Camprol, ondansetron, Zofran, or buprenorphine, Buprenex, and use of behavioral treatment to help the client learn substitute behaviors. Clinical management and maintenance of sobriety. Persons may require ongoing treatment for comorbid psychiatric disorders. May use aversion treatment to avoid alcohol in persons with alcohol dependence. Examples of aversion treatment medications are disulfiram, which is antabuse. Now, with antabuse, do not administer until the person has been alcohol-free for at least 12 hours. Advise the client to refrain from using anything that contains alcohol, even vinegar, aftershave lotion, perfumes, mouthwash, and cough medication, while taking disulfiram, and up to 2 weeks after discontinuation of disulfiram, should the patient avoid using these products. Disulfiram can elevate liver function tests, so monitor. Antabuse may potentially induce mania in people with bipolar disorder. General health maintenance medication to treat vitamin deficiencies in persons with alcohol dependence include thiamine, folic acid, and B-complex vitamins. Pharmacological agents useful in treating craving and maintaining. There's a chart that gives credit to Stahl 2014 for this chart. Citalopram, Celexa, which is an SSRI, it apparently decreases the desire. Disulfiram, antabuse, is aldehyde dehydrogenase inhibitor, and it's aversion therapy. Naloxone, Narcan, is an opioid antagonist antidote. It blocks the effects of opioids. Buprenorphine is Buprenex, and it's an opioid partial agonist and partial antagonist, decreasing cravings. Buprenorphine and naloxone combination is Suboxone, and it's a narcotic analgesic, which is an opioid agonist and antagonist. Methadone dolphin is a narcotic analgesic, and it suppresses withdrawal. Nalmefene or Revex is an opioid antagonist, increases abstinence. IM Revia Vivitrol is an opioid antagonist, and it increases abstinence. And a camprosate, Camprol, is it decreases cravings. Non-pharmacological management. There's multimodality treatment is needed. Lifetime treatment is often required. Inpatient treatment is usually needed for safe and effective withdrawal from alcohol. Indications for inpatient alcohol detoxification include a history of severe withdrawal symptoms, seizures or delirium tremens, multiple past detoxifications, additional medical or psychiatric illnesses, recent significant alcohol consumption, and lack of a reliable support system, and pregnancy. Reduce central nervous system stimulation by maintaining a quiet environment. Put the client in a room close to the nurse's station to facilitate frequent observation and monitoring. Minimize abrupt changes in environment. Decrease bright light and sharp sudden noises. Decrease room clutter and do not restrain. Maintain hydration by monitoring intake and anticholinergic effects of benzodiazepines, and frequently offer fluids. Before discharge from an acute care setting, have a definite plan for follow-up treatment. Connect support groups. Connect client and family with support groups. That's 12-step groups in the community, and concrete plan for the first week of support group attendance may be needed even daily. So the first week might be needed daily. And connect the client with counseling and psychotherapy. Identify a primary healthcare provider. Note medical problems that will require further evaluation and potential treatment. Neurological sequelae of chronic alcohol consumption, nutritional deficiencies, cardiomyopathy, hypertension, arrhythmias, ischemic heart disease, blood dyscrasias, gastrointestinal inflammations, esophageal, liver, nasopharyngeal, and laryngeal cancers. Client care needs are substance abuse education classes, substance use counseling programs, continued 12-step programs, halfway housing, and cognitive behavioral therapy. Family care needs are current and understandable information about condition, progress, and treatment plan. Connect family to community support groups such as Al-Anon or Al-Ateen. Management of feelings such as guilt and anger, and referrals of community resources. Specific considerations: relationship with the treatment, the role strain, financial stresses, social isolation, incorporating the drinking member back into the routines, encouraging further counseling to resolve these difficulties, and refer for further treatment if family members report symptom clusters from anxiety and mood disorders, eating disorders, and addiction. Lifespan considerations: children and adolescents. Most common period for starting drug use is children and adolescents. Significant impact of peer pressure on substance use patterns. 30 to 40% of adolescents report drinking frequently, and 15% report binge drinking patterns. Approximately 50% of high school age students report at least one-time use of illicit drugs. 50%. Okay. Older adults. Refer to specialized treatment program that emphasizes interventions to deal with losses. Large print psychoeducation material, transportation to service locations, treatment with same age peer group, adaptations to home environment to cope with physical disabilities, and use of collaboration with primary care physician for follow-up. And that is a wrap for this chapter.